Medicina Crítica, en su 24ª edición. Les agradecemos muchísimo el conectarse nuevamente con nosotros. Mi nombre es Pedro Alvarado, soy un internista y un intensivista egresado del Instituto Nacional de Nutrición Salvador Subirán, aquí en la Ciudad de México. Yo los voy a estar acompañando durante las presentaciones o a lo largo de las presentaciones que tenemos preparadas el día de hoy para todos ustedes. Estoy seguro que el día de hoy cerramos con broche de oro. Vamos a tener la participación de 8 ponentes de renombre internacional que nos van a hablar de distintos temas de gran importancia para la medicina crítica de la actualidad. Entonces, pues sin más, procedo a presentarles exactamente de quién estamos hablando. Vamos a tener la participación del doctor Iwan Golliger. Él tiene programadas 2 sesiones. Nos va a hablar de disfunción diafragmática en ventilación mecánica y también nos va a hablar sobre el tema de volumen corriente contra presión de conducción o driving pressure en síndrome de insuficiencia respiratoria aguda. El doctor Golliger es profesor asistente en la División Interdepartamental de Medicina Crítica de la Universidad de Toronto y es científico clínico en University Health Network. También vamos a contar con la honorable participación del doctor Jean-Louis Teboul. Él nos va a hablar de 2 temas también. Él nos va a hablar sobre el manejo hemodinámico en pacientes con COVID-19 y también nos va a dar una actualización sobre la evaluación de respuesta a líquidos. El profesor Teboul es profesor de terapéutica y medicina de cuidados críticos en la Universidad París-Sur en Francia y ejerce su actividad clínica en la Unidad de Cuidados Intensivos Médica del Hospital Universitario de Bicêtre. Posteriormente vamos a contar también con la participación del doctor Philip Dellinger. Él va a tener una intervención en cuanto a presión de conducción o driving pressure y reclutamiento alveolar. Él es profesor de medicina y distinguido académico en la Cooper Medical School de la Universidad de Rowan. Es asistente de cuidados críticos senior y director del Cooper Research Institute en Cooper University Healthcare. Y además es profesor adjunto en el Departamento de Medicina Pulmonar de la University of Texas MD Anderson Cancer Center. También vamos a continuar posteriormente con la participación del doctor Luciano Gattinoni, quien nos va a hablar sobre ventilación mecánica invasiva en el paciente con COVID-19. Él actualmente es profesor de anestesia y cuidados intensivos de la Universidad de Göttingen, Alemania. Y bueno, pues es quien introdujo el concepto del baby lung o pulmón de bebé, que ha servido como un marco conceptual para el desarrollo de la investigación sobre la fisiopatología del SIRA como tal. Asimismo, vamos a contar con la participación posteriormente de la doctora Janice Zimmerman. Ella nos va a hablar sobre trombocitopenia trombótica, HIT y más. La doctora Zimmerman es intensivista en Houston, Texas. Ella actualmente tiene licencia para ejercer en medicina en Texas, Wyoming y Minnesota. Es profesora adjunta en el Colegio de Medicina de Baylor y presidenta de la Federación Mundial de Cuidados Intensivos y Críticos. Posteriormente vamos a tener la participación también del profesor Jean-Louis Van Sant. Él también va a tener 2 intervenciones, una de ellas titulada Necesitamos SIRA, y la siguiente será acerca de la SVO2, la relación entre aporte y consumo de oxígeno. Actualmente es profesor de Medicina de Cuidados Intensivos en la Universidad Libre de Bruselas, intensivista en el Departamento de Cuidados Intensivos de la Universidad Erasmus Hospital de Bruselas, Bélgica. Además de que es miembro de la Real Academia de Medicina de Bélgica, fue nombrado varón por el rey de Bélgica. Posteriormente vamos a contar también con la participación de Eddie Fan. Él nos va a hablar sobre ECMO para pacientes con COVID grave. Él es profesor asociado en la División Interdepartamental de Medicina de Cuidados Críticos y en el Instituto de Políticas, Gestión y Evaluación de la Salud de la Universidad de Toronto. Es intensivista en la red de salud de la Universidad del Hospital Mount Sinai. Y finalmente vamos a contar también con la participación del doctor John Marini. El tema del cual él nos va a hablar es: ¿necesitamos cambiar nuestro abordaje para ventilar pacientes con SIRA? Él es profesor de medicina en la Universidad de Minnesota, recibió su título médico en la Universidad de Johns Hopkins y ha servido anteriormente como profesor en la Universidad de Washington y en la Universidad de Vanderbilt. Él es miembro del consejo editorial de múltiples revistas científicas y educativas de alto rango. Estas van a ser las participaciones que vamos a tener. Vamos a empezar con la del doctor Iwan Golliger en cuanto a disfunción diafragmática. Entonces, sin más, pues por favor, doctor, bienvenido.
Good morning.
Y es un verdadero placer que me hayan
This morning, my first talk is on diaphragm dysfunction in mechanically ventilated patients. And I want to briefly cover how we assess diaphragm dysfunction and why it matters in terms of the patient's outcomes. These are my disclosures. So the diaphragm is the primary muscle of inspiration. It's a large dome-shaped muscle that acts as the barrier between the thorax and the abdomen. And it's arranged such that it inserts at the bottom of the rib cage, and then there's a zone of apposition that runs abutting the rib cage, and then the muscle peels off the rib cage to form a dome. It's composed of a couple of different regions. There's the costal diaphragm, which inserts into the rib cage, of course, then the crural diaphragm, which inserts onto the vertebral column, and then there's a ligamentous region at the center of the diaphragm called the central tendon, which is where the various vessels transit through the muscle. In terms of understanding the action or motion of the muscle, I think it's important to appreciate that it primarily functions much like a piston within a cylinder. So when the diaphragm contracts, there's relatively little shape change in the muscle, but the dome descends and the zone of apposition shortens so that it's acting like a piston in a cylinder. Now, there is an interesting oppositional force of the diaphragm. So as the dome descends, the abdominal pressure underneath the diaphragm increases, and that actually pushes the rib cage outward. That's the so-called appositional force of the diaphragm. This figure nicely illustrates the functional mechanics of the muscle. So when the crura of the diaphragm contract, that pulls the dome of the diaphragm down, but at the same time, contraction of the costal region elevates the bottom of the rib cage. And then there's also the appositional force, which pushes the rib cage outward. So the muscle effectively, when it contracts, lowers the dome, raises the rib cage, and forces the rib cage outward. So it's a very efficient mechanism for generating an increase in thoracic volume and for ventilation. Now, how do we assess the function of the muscle? Well, like any muscle, you assess its function in terms of its force generating capacity. And in order to assess force generating capacity, you need a standardized stimulus to the muscle. Now, conventionally, that's done in healthy subjects by a maximal inspiratory pressure, also called a negative inspiratory force, where the subject makes a maximal effort against an occluded airway, and you use that pressure measurement to assess the force generating capacity of the muscle. In critically ill patients, this is challenging, of course, because many patients are unable to participate or to follow instructions, and therefore the reliability of volitional maneuvers can't really be counted on. So one of the most important techniques that's been developed is the use of magnetic twitch stimulation of the phrenic nerve, which generates a standardized stimulus to the phrenic nerve, and the airway pressure during an airway occlusion developed during a magnetic twitch stimulus provides a useful measure of and a valid measure of diaphragm function. But this is an extremely tricky technique. Having used it myself, I can tell you honestly, it can be challenging to position the magnets correctly. There's a lot of different factors that can interfere with the stimulus. So it remains largely a research technique. And some of the most important studies in the field have been published using this technique, but it would be hard for this technique to make its way into routine clinical practice. One of the important methodological and technical advances in the field was the widespread introduction of diaphragm ultrasound. So this technique can be performed in a couple of different ways. I'm going to show you the measurement of diaphragm thickness here, which is performed by placing a linear array probe on the side of the hemithorax. And you can visualize the diaphragm in cross-section. Here's the pleural line and the peritoneal line, and this zone in between those two lines represents the muscle. And you can see that it's the diaphragm muscle because whenever the muscle contracts, you can see it thickening up very nicely. This is an image from a healthy subject here. So you can see as the muscle contracts, it shortens and hence it thickens in the zone of apposition. And this technique allows you to image that thickening. And if you place the ultrasound in M mode, you get an image similar to what is shown here on the right, where you have at time points A and C, you have expiratory relaxation, and then at time points B and D, you have the peak inspiratory thickness of the muscle. And this turns out to be a useful non-invasive surrogate for contractile activity of the muscle and the contractile force generated by the muscle. And so this allows us to make measurements in mechanically ventilated patients. And because it's non-invasive, it doesn't require esophageal instrumentation or magnets, it's really made a large-scale study of the diaphragm much more feasible in the clinical setting. Now, just in terms of understanding the physiology of diaphragm thickening, it's important to appreciate that, as I said, when the diaphragm contracts, its shape or conformation changes relatively little in this axis. So you can see that in cross-section, the actual shape of the dome isn't changing very much in this MRI study. What is changing markedly is the length of the zone of apposition. So here at rest, this black point here represents the point where the muscle starts to abut the chest wall. And you can see that during inspiration, the length of the muscle is markedly reduced so that now it's abutting the chest wall at this point. So what this means is that shortening and thickening of the muscle in the zone of apposition is a very good surrogate marker for the degree of muscle contraction. You can see that here in this figure, again in healthy subjects, where as inspiratory volume as a percentage of inspiratory capacity increases, the thickening fraction of the muscle increases. This has been well validated as a useful measure of muscle function in mechanically ventilated patients. The paper here, figure here on the left, is from a study in ventilated patients that compared the thickening fraction measure to the twitch airway pressure using magnetic phrenic nerve stimulation, the gold standard technique. And you can see here a fairly nice correlation between the two, so that when the thickening fraction is high, that also implies a relatively high twitch airway pressure generation. When thickening fraction is low, particularly below 20%, that's consistent with a relatively low twitch airway pressure level. And you can see here that in terms of sensitivity and specificity for the diagnosis of diaphragm dysfunction in mechanically ventilated patients, the twitch airway pressure and the thickening fraction of the diaphragm perform relatively similarly. So this is a very useful technique. It's quite a reliable technique, and it's very easy to learn. It's much easier than many of the other ultrasound and echocardiographic techniques that are now routinely employed by intensivists. So I'd encourage you to read some papers about this and to try it out at the bedside. You'll find it's eminently feasible. So with that kind of physiology and functional assessment background in mind, let's think about the importance of diaphragm dysfunction in mechanically ventilated patients. There's many reasons why ventilated patients develop diaphragmatic weakness. Sepsis and systemic inflammation, the electrolyte imbalances associated with critical illness, potassium and phosphate derangements in shock states with decreased muscle perfusion, some of the medications we administer, of course, including steroids, certain antibiotics such as aminoglycosides, the residual effects of neuromuscular blockade. Of course, there's the extremely well recognized phenomenon of critical illness neuromyopathy, which can affect both the diaphragm and the phrenic nerve. And interestingly and importantly, over the last 20 years, we've come to appreciate that the ventilator itself is an important cause of diaphragm injury and dysfunction. And so when increasingly we recognize that when we're setting the ventilator, we need to consider how those settings might affect the diaphragm. And this leads us to the concept of diaphragm protective ventilation, which has now been widely discussed in the literature. So what is some evidence that the diaphragm matters in terms of patient outcomes? Well, this is a study that we published a year and a half ago, demonstrating an association between the thickness of the diaphragm at baseline after patients have been intubated and the clinical outcomes. So you can see here that in this cohort study of about 200 patients with a higher baseline diaphragm thickness had better survival over time compared to patients with a reduced diaphragm thickness at baseline. So these are patients who are coming into the ICU with diaphragm atrophy. And of course, this may be a reflection of chronic frailty or muscle weakness versus an intrinsic impact of the muscle atrophy on the outcome per se. But it indicates that the diaphragm atrophy and weakness is clearly associated with higher mortality rate. And this association persisted in multivariable analysis. Similarly, patients with a higher baseline diaphragm thickness are liberated from the ventilator at a higher rate over time. And so the risk of prolonged mechanical ventilation is higher for patients who enter the ICU with a reduced diaphragm thickness. Diaphragm weakness, diagnosed by twitch airway pressure measurement, is associated with important patient-centered outcomes, including difficult or prolonged weaning or death in hospital. This figure here shows the relationship between the risk of difficult weaning or prolonged weaning or death in the presence or absence of diaphragm weakness. So if you focus here, this bar here shows that patients with diaphragm weakness have nearly 50% chance of encountering difficult weaning and is markedly elevated in comparison to patients without diaphragm weakness. Similarly, patients with diaphragm weakness are at much higher risk of prolonged weaning and of death in hospital. Now, it's also striking to note here from this very nice paper by Martin Dress and colleagues, the group in Paris, is that the clinical outcome, the difference in clinical outcome between the presence and absence of diaphragm weakness is much more marked than it is for the presence or absence of limb muscle weakness. And so I want to emphasize that while peripheral muscle weakness gets a great deal of appropriate attention as an important form of ICU-acquired weakness, respiratory muscle weakness is, if anything, a stronger predictor of some of these important near-term patient outcomes. On the other hand, I would point out that limb muscle weakness seems to be more strongly associated with long-term functional outcomes. So both of these forms of muscle weakness, they develop at different times. They're not specifically associated with each other in the short term, and they have different associations in terms of long-term outcomes. So diaphragm weakness should not be thought of simply as another kind of peripheral ICU-acquired muscle weakness. These are two different clinical entities. Respiratory muscle weakness is also associated with a higher risk of long-term mortality over the year after ICU discharge. And so this highlights that the sequelae of the development of diaphragm dysfunction may be an important determinant of the patient's long-term functional status. And so targeting and improving diaphragm function may be associated with an accelerated recovery from critical illness and a better long-term patient outcome. And not only has measurements of respiratory muscle strength and diaphragm strength in terms of twitch airway pressure and maximal inspiratory pressure been associated with outcome, but the ultrasound-based measurements have also been clearly associated with outcome. This is a nice analysis here by Clement Medrinol, who showed that across many studies, a reduction in diaphragm thickening fraction is associated with a higher risk of death, and similarly with a higher risk of weaning failure. So consistently across many, many studies, a reduced diaphragm thickening fraction is predictive of mortality and prolonged mechanical ventilation. So this again reinforces the clinical relevance of this simple clinical measurement at the bedside. Now I want to, in the time that remains to me, just very briefly cover the specific entity of ventilator-induced diaphragm dysfunction. This was first recognized in the 1980s. It was described by Knisley and colleagues in autopsy study of neonates. Neonates that were on the ventilator for only a very short period of time before they died had relatively normal myofibrillar cross-sectional area of the diaphragm. And by contrast, you can see this fibrosis and marked myofibrillar cross-sectional area reduction in neonates that had been on the ventilator for a much more prolonged period of time. So this was really the preliminary observation that raised the possibility that mechanical ventilation might cause diaphragm atrophy. And subsequently in animal models, it has been repeatedly demonstrated that even a short period of passive mechanical ventilation for 24 hours is associated with a rapid onset of profound diaphragm atrophy and dysfunction. And so this early disuse phenomenon seems to be a very important mediator of diaphragm weakness in mechanically ventilated patients. And in fact, there's probably several different mechanisms, not only disuse of the muscle from over-assistance, but also load-induced injury from under-assistance, and possibly injurious forms of loading associated with certain types of patient ventilator dysynchrony. There may be multiple different mechanisms of diaphragm injury from mechanical ventilation, and this may account for the fact that diaphragm weakness is so prevalent in this population. This is the seminal paper that demonstrated the phenomenon of disuse atrophy for the first time in humans. You can see here that in comparison to controls, which were patients undergoing thoracic surgery for just 3 or 4 hours, cases which were brain dead organ donors who'd been brain dead for anywhere between 18 to 69 hours exhibited a marked myofibrillar atrophy of both slow and fast twitch fibers. And interestingly, this seemed to be diaphragm specific. There was no difference in cross-sectional area between cases and controls for the pectoralis major muscle. So this finding really was probably the first in-human demonstration that mechanical ventilation was associated with disuse diaphragm atrophy. There's also evidence to support the development of load-induced injury, as I mentioned. So just a short period of elevated resistive loading can result in marked muscle injury. So here, the control specimen, you can see the kind of beautiful and very well-organized muscle architecture. And just after resistive loading, you see inflammatory infiltration and breakdown of these muscle fibers, indicative of acute load-induced muscle injury. And when the muscle is inflamed as a consequence of sepsis, it is much more vulnerable to load-induced injury. So this may be really an important issue and reason why patients may develop diaphragm injury even before they're intubated, because if they're septic and systemically inflamed and then making vigorous inspiratory efforts to sustain ventilation in the context of respiratory failure, well, that may mediate load-induced injury even before they're intubated. And then if they're insufficiently supported after they're intubated and their respiratory effort levels remain high, that may mediate further load-induced injury. In this cohort study of diaphragm thickness over time that we published now several years ago, we demonstrated that the diaphragm atrophy during mechanical ventilation was exceedingly common. So we identified 3 different groups: patients who had relatively stable thickness over time. This was about 40% of the population, 45% of the population. Another group who developed a rapid early decrease in diaphragm thickness over time, and this again was about 45% of this cohort of patients, about 100 or so patients. So this demonstrated for the first time that this phenomenon of acute diaphragm atrophy during mechanical ventilation is extremely common in our patients. And interestingly, there was a small subset of patients who had a rapid early increase in diaphragm thickness, which may be indicative of inflammation from load-induced injury, although that remains more of a speculative hypothesis at this point. These changes that we observed in the diaphragm during mechanical ventilation were clearly associated with outcome. So patients who had no change in diaphragm thickness from baseline had liberated at a relatively high rate in comparison to patients who had either a decrease or an increase in diaphragm thickness. You can see the risk of prolonged mechanical ventilation at day 21 is essentially doubled in the patients with early changes in the diaphragm within just 3 or 4 days of mechanical ventilation. So this is a very early phenomenon that is strongly associated with long-term consequences for these patients. And again, this association between an increase in diaphragm thickness during mechanical ventilation and poor outcome suggests that this is representative of or indicative of some kind of muscle injury that we don't fully understand. Similarly, there was a clear dose-response relationship between either decreases or increases in diaphragm thickness and the duration of ICU admission, which is a strong predictor of long-term functional outcome, and also of the risk of complications of respiratory failure, a composite of reintubation, tracheostomy, prolonged ventilation, or death. So preventing these changes in diaphragm thickness by optimizing patient respiratory effort might actually have an important benefit in terms of clinical outcome for patients. It might accelerate ICU liberation and prevent complications of respiratory failure. And interestingly, when we looked at the relationship between patient inspiratory effort measured by ultrasound, the diaphragm thickening fraction, which represents the contractile activity of the muscle, we looked at the relationship between that value over the first 3 days of ventilation and the duration of ventilation. There was this very interesting J-shaped relationship where patients with relatively low or absent respiratory effort or relatively elevated respiratory effort both exhibited a more prolonged duration of ventilation than patients with intermediate levels of respiratory effort. And of course, this is an observational finding. It's not, we can't draw firm causal inferences, but it suggests that possibly by targeting an intermediate level of respiratory effort, consistent with that seen in healthy subjects breathing at rest. If I was to measure diaphragm thickening fraction in most of you breathing at rest, it would probably be in the 15 to 30% range. And so if we targeted that level of effort under mechanical ventilation, perhaps we could avoid the injuries resulting from atrophy or from excess loading. And this leads really to the concept of diaphragm protective ventilation, which I would say was first articulated by Tobin and colleagues in a seminal review in Annals of Internal Medicine back in 2010. They wrote that to navigate a patient's safe passage between the scala of excessive patient effort and the Charybdis of excessive respiratory muscle rest, we suggested clinicians carefully titrate ventilator settings and pay close attention to the contour of the airway pressure waveform. So really, when we're at the bedside, we want to paying close attention to the patient's level of respiratory effort, something that I'll speak to a little bit more in my second presentation. And I think by doing so, we may be able to avoid diaphragm disuse atrophy and also load-induced injury and thereby improve outcomes for patients. So thank you very much. Be happy to take questions.
Thank you, doctor, so much. We will do the countdown. 3. Thank you, doctor, for your presentation. I honestly believe that this has been really wide-opening because it's like taking a look at the other side of the coin to know how to ventilate our patients, and not only to protect the lung, but also the diaphragm. We would like to ask some questions coming from our team and from our participants, from our attendees. The first question is, we understand that diaphragm dysfunction has some well-shown prognostic elements, but in which patients would you recommend for us to look for the diagnosis of diaphragm dysfunction? I mean, in any patient that is being mechanically ventilated for more than 48 hours, or in patients who had a difficult ventilator weaning. And also, will the diagnosis help you make a specific clinical decision? Those who have prolonged ventilation will undergo tracheostomy, for instance.
Sure. Thank you. That's a great question. I think that the available evidence would suggest that it's useful to measure diaphragm function in patients who develop or encounter difficulties being weaned from mechanical ventilation. I agree that perhaps the measurement doesn't need to be made in all patients, and certainly in my clinical practice, I don't do that myself. But if I have a patient who's encountering difficulty being liberated from mechanical ventilation, and particularly if they repeatedly fail the spontaneous breathing trial, I think it's very important to try to understand why that's the case. And so assessing the diaphragm function in a patient like that helps us to understand why the patient's failing liberation from mechanical ventilation. And that in turn provides, useful diagnostic, prognostic information. If a patient has severe diaphragm dysfunction, then it's clear that we need to be patient. It's going to take some time for the patient to recover and be able to be liberated. And so it sort of helps to set expectations for the clinical team, for the patient and the family. In my practice, I didn't have an opportunity to review this literature, but in some patients with persistent weaning difficulties who have diaphragm dysfunction, I'll initiate specific inspiratory muscle training, which is a relatively easy technique to activate the diaphragm, to try and strengthen it. It's been proven to effectively improve respiratory muscle strength. So we have a paper in the literature describing that technique and describing the evidence for it. And so sometimes in patients with diaphragm dysfunction on ultrasound, I'll arrange for inspiratory muscle training. But the diaphragm is activated in the context of all mobilization and all postural activities. So just having the patient dangling at the bedside, up in the chair, standing, walking, to strengthen the core, I think will help to rehabilitate the diaphragm as well.
Thank you, doctor, so much. I fully agree with you. And we would also like to ask whether there are any pharmacological interventions, triptyline, for instance, or other drugs that have been used to improve the diaphragm function once we have a diagnosis.
There are no pharmacological agents that I'm aware of that have a meaningful clinical benefit. Certainly there are drugs, as you mentioned. Also, levosimendan is another drug that's been studied quite a lot to strengthen or increase diaphragm contractility. But none of these agents really seem to have a clinically important benefit, at least given the present literature. And of course, they carry side effects or risk of side effects in these patients that we may generally want to avoid. So I don't think there is evidence to support routine use of pharmacological agents to treat diaphragm weakness.
When we measure the diaphragm thickening fraction, we know that there are several elements that may modify thickening. So for us to be able to correlate this with the gold standard, which is the pressure generated through electromagnetic stimulation, which are the support levels that we should give to the patient when doing the measurement so that we can make an appropriate diagnosis based on that specific measurement?
Yeah, thank you. That's a very thoughtful question. So I would say that the answer to the question depends to some extent on why you're doing the measurement. If you're doing the measurement to assess the patient's diaphragm contractility during tidal breathing, then you don't need to make any adjustments to the ventilator at all, because the thickening of the muscle represents its contractile activity. And so if you just put the probe on and under the current ventilator settings, you see that thickening is absent, or that there's a lot of thickening or just a little thickening, that tells you about the activity of the muscle under those conditions. On the other hand, if you want to assess the maximal performance of the muscle to assess its function or its strength, then you want to create conditions for the measurement that lead to maximal diaphragm activation by the patient. So just as when you measure MIP, you try and coach the patient to do a maximal inspiratory effort, you're going to have to try and do the same thing when you're measuring maximal diaphragm thickening fraction. So the way that I do this is to temporarily put the patient in CPAP, or continuous positive airway pressure, to try and take away the respiratory support in order to increase their respiratory drive and effort. Or I'll put them in sort of the minimum level tolerated pressure support to sort of try and maximize their respiratory effort level. If that doesn't lead to vigorous inspiratory efforts, which you can kind of assess just by looking at the patient, looking for accessory muscle use, etc., then what I'll do is I'll apply a temporary airway occlusion. This is the so-called Marini maneuver. And so that temporarily occludes the airway, forces the patient to make larger efforts. And then once the airway occlusion is released and the patient is still making vigorous inspiratory efforts, but inhaling and exhaling, that's the time when I will do the thickening fraction measurement. And that's basically a way of getting the muscle to be maximally stimulated in order to assess its function. So that's how I go about using the ultrasound to assess maximal thickening fraction.
Thank you so much, Doctor. Let me check if there are any other questions. Is there any relationship between nutritional support the patient has received and diaphragm dysfunction development? I mean, nutritional status has anything to do with developing this pathology?
Interesting question. Not that I know of, to be honest with you. The studies that I've seen have not found an association between nutrition in the ICU and the diaphragm, but I wouldn't say there's any definitive studies on the topic. Certainly, patients who come in at baseline with relatively atrophic diaphragm are at higher risk of poor outcome, like I showed at the beginning. And many of those patients, some of that will have global muscle atrophy, not just diaphragm atrophy. And some of that may be nutritional nature, may also be reflective of chronic lung disease and so on, and the kind of metabolic effects of chronic respiratory disease. So I think nutrition is an important consideration, but it certainly doesn't explain the development of diaphragm atrophy or weakness during the early course of the ICU admission. That has much more to do with the level of activity of the muscle.
Thank you, Doctor, so much for all your answers. And now we will move on. We will go back to you, after our next talk, but we will now close this part and we will give the floor to Dr. Jean-Louis Deboul. Thank you.